sure where I got to on the slide, so I think I might just start this slide again. Before a competition, you could also think about before training, that one of the goals of that meal before you compete is to make sure that you're not hungry at any point during the game or the event, and that you, on the other end of the scale, you're also not left with food that's undigested in your stomach. Remember that we looked at in the cardiovascular chapter the fact that when we start to exercise, our blood flow gets diverted away from the stomach and the kidneys to the working muscles. So you don't want a lot of undigested food sitting there. That's going to make you feel uncomfortable and kind of sluggy. Also, it needs to be pretty low in fat and fiber. That will help increase gastric emptying and minimize gastrointestinal distress. So the recommendation is somewhere usually, depending which resource you look at, somewhere between 2 to 3 hours before you compete. If you eat too close to the competition, so within a half an hour, for some individuals that spikes a real high insulin response, and then we see an immediate drop in blood glucose, and so that can leave you feeling lightheaded and starving within 10-15 minutes of starting. So that's not good, but that's an individual thing you have to kind of test out for yourself and keep track of, because not all people indicate that very strong response. So for some people it's okay to snack just beforehand, all right? If you're someone that has a problem with blood glucose, you're probably better to wait and snack once you've started exercising. So somewhere between 200 to 300 grams of carbohydrate. Remember that carbohydrate is the primary source of energy. So we want to make sure that we've got carbohydrate and our blood sugar levels are at nice and stable going into the competition. You might need it, if you're having something within an hour, then you may need it to be a liquid meal to maximize gastric emptying. Or if you're someone that gets very, very nervous and you can't take something solid because that will make you feel nauseous, okay? Or you get cramps easily, so sometimes that's a good time to use a carbohydrate drink. Also, if you're in a sport where you have multiple events in a day, then the recommendation is that carb drinks can be useful there rather than trying to eat solid food, because you don't have enough time to digest it in between events. Okay? And the last point you would think would be relatively obvious, but I'm assuming that maybe it's not, because otherwise they wouldn't have it in the book. Want to make sure, don't eat anything new before a competition. So if you're feeling a little hungry and a teammate or someone else says, oh, I have this granola bar, you can eat that, and you've never had that particular granola bar before, the best plan is not to eat that, right? Because you don't know what your stomach's response is going to be, okay? And you don't want to have gas and cramping when you're trying to compete, all right? So after the competition, the goal is really to aid recovery by restoring glycogen as quickly as possible in the liver and in the muscles. So we want to make sure that we have plenty of carbohydrate. If you can, the recommendation is to try to eat some carbs every 15 minutes for up to 4 hours. But you've got to watch your calorie intake, right? So be careful what you pick there, right? If you don't need to replenish your glycogen stores that quickly, because you don't have to compete again the next day, perhaps, then you can have something straight after you finish and every 2 hours or so. Right? So then remember when we were looking at the protein information, after the competition, you might want to have some protein and some carbs. So you could use a protein carb shake, or you could use something as simple as a peanut butter sandwich, right? We want to make sure that we've got amino acids available for repairing the damage to the muscle tissue, all right? Let me see here, what else? Did I have? No? That's good, I think. So remember the American Dietetic Association ratios, okay? Those are probably the simplest way to look at whether or not you've got your food sources balanced, and then look at myplate.gov or one of these other institutes that has, like, you need X servings of veg and fruit and starch and protein in a day or a week, right? So try to combine those two ideas. Carbs want to be between 45 to 65% of your calorie intake. For a normal type person who isn't an athlete, usually that's 45 to 50% or so. Fats want to be less than 30% of your intake, and the saturated fats need to be less than 10%. And then proteins between 10 to 35%, but remember that idea about 2 grams, around 2 grams, it is really the limit, 2 grams per kilogram of body weight, because at that point you're really stressing your kidneys quite a lot, right? So most people don't need anywhere near that amount of protein. Okay, 0.8 grams per kilogram per day is recommended for our normal, typical, kind of relatively sedentary person. So most of us overeat protein anyway, so you may not need to be adding additional protein once you actually calculate what your diet is like. Okay. And then last little graph, just to show you, and this is glycogen synthesis, not protein synthesis, okay? But this is kind of what happens if we eat some carbs within 2 hours. We see really good levels of glycogen synthesis, right? If we leave it for over 2 hours, we don't get such good levels, okay? So you want to try to get some carb and protein in within that 2-hour window, okay? Whether you're training or competing, really. So I think that's it for, is that chapter 9? I think that might be chapter 9, I can't remember the number. And then I was mistaken on Wednesday. I forgot that I flipped around the chapters at this point because there is an assignment coming up that we have, that the information for that assignment is in chapter 13. And if we do chapter 10 next, which is the fluids and electrolytes, then you end up having to do quite a big assignment right on top of the next exam, which isn't really very happy making, I don't think. So I flipped around. We're going to do chapter 13 first so that you can get going on that assignment next week, and then we'll come back to fluids and electrolytes once we've looked at exercise prescriptions. Okay, so we are going to start chapter 13. Oh, and it says chapter 12. That's wrong. It's chapter 13. Make. Okay. All right, so we're going to look at, as I said, exercise prescriptions, not just for athletes. All right, so we're going to look at a matrix that you can use for most people you're going to come across. Possibly not someone who's very unhealthy or very obese, or has just come out of surgery, possibly, something like that. But for the majority of people that you're going to deal with, whether they're athletes or non-athletes who want to train or be physically active on a regular basis, or even complete beginners. So the matrix that we'll come up with will cover that whole range. Okay? So the first thing we're going to do is look at cardiovascular disease and coronary artery disease, because the research is so strong on the benefit of being physically active on these problems, and they are responsible for a lot of deaths in America. So we want to try to understand how we can use our exercise prescription to try to benefit people, either stop them getting these diseases in the first place, or at least mitigate the long-term effects for them a little bit, right? Okay, so kind of like the difference that we talked about earlier in the semester between using the term exercise and using the term physical activity. You want to be careful who you use those terms with. We've got a similar situation when we're looking at the exercise, the benefits of an exercise prescription, right? So we can set this prescription so that we significantly increase an individual's fitness if they were in good enough shape in the first place, right? And that's their goal. So we can see physiological adaptations that are quite sophisticated if we want to set that level, right? But we're also able to use the same concept to set a prescription for health benefits. So we want to see adaptations such as lower blood pressure, lower fat mass, okay, that reduce the risk of disease for these individuals. So it's very important when we talked about setting your goals for your physical activity log, it's very important that if you're going to work with athletes or school kids or family members or private clients, whoever it is, that you understand what their goal is, right? Because they may not want to be super fit. That might not be really in their ballpark, right? They may just want to spend time getting more healthy, okay? And it's important that we understand the difference in the level of activity and intensity that we would set for that, right? So we're going to look at intensity again. We looked at it earlier in the semester so that you could think about it for your logs. It really is a key variable for achieving any goal that you set. for yourself or that your individual sets for themselves. We also need to look at the volume of training, so how much work is being done in the training program. If we're aiming for health benefits, we don't need the intensity to be so high or the volume to be so large, right? So it really depends who we're working with, what their goals are, okay? Okay, so we're going to look at coronary artery disease, and as I said, the impact here on these health issues is truly significant from a relatively small amount of physical activity. Certainly, if you're a competitive athlete right now, the amount of work that needs to be done to impact this idea, you would think of as basically not exercising at all, probably. All right? So again, try not to be judgmental. Remember, it's not your goal, it's someone else's goal. Okay? So coronary artery disease then is defined by a blockage of the arteries that are supplying the cardiac tissue. So again, when we did the cardiovascular chapter and we looked at the blood supply to the actual myocardium, and we said that the right and left coronary arteries are the two main ones, and then they branch off into smaller arterioles and capillaries. All right? So if we've got CAD, then that means that one or other, or if you're really unfortunate, both of those coronary arteries are blocked to some extent. Okay? Now, the term ischemia means that there's insufficient blood supply to a portion of tissue due to a partial blockage or a full blockage, right? Usually a partial blockage, because if it's a full blockage, you're not likely to get just pains in your heart, you're going to have a full-blown heart attack probably. Most common, and this is why it's important for us as movement people to understand this, when there's only a partial blockage of the artery, the heart gets blood and oxygen, and unless you stress the heart, you could live with that blockage for a long time and never really know it was there. So often what happens is someone will start exercising, and it will be during the physical activity or the exercise that they recognize symptoms of pain or worse, right? So if you're the person in the gym running the training program, it's highly likely that you might see someone like rub their arm or rub their chest, and then they sort of shake it off and they keep going. You need to jump in there and talk to that individual, because they may not know they have this blockage and they're not recognizing that this symptom could be really serious, right? So you need to keep an eye out for what kind of behaviors are you seeing that maybe you shouldn't be seeing, okay? So this ischemia, partial blockage, can lead to severe chest pain, but you know what? The people I know that have had this say it kind of feels like indigestion, right? So they think they've got indigestion. They don't realize that they're having a mini heart attack almost, right? So, as I said, angina is a serious problem that you want to intervene if you think anybody is feeling that kind of pain, okay? Then the next one, myocardial infarction, is the fancy term for a heart attack. Okay, and depending on the level of your progress of the blockage, you could have a complete heart attack in your 20s or early 30s, right? If you're lucky and the progress of your blockage is very slow, you may never have a heart. You might die of something else before you have a heart attack, right? So you can't, if you think you've got angina, you don't want to ignore that because you want to catch it before you get a complete blockage that leads to death of the heart muscle, the other side of the blockage, and a heart attack. Okay? Two fancy terms, and they're a little bit similar, so they get a bit confusing, so spend a little bit of time just making sure you've got those straight. Atherosclerosis is narrowing of the artery due to plaque buildup, and arteriosclerosis is thickening and loss of the elasticity of the arterial wall. Remember we said that the arterial walls are a little bit stretchy, and not as stretchy as the veins, but they're pretty stretchy, and what happens is they get thicker and thicker and they get stiff. And then they can't stretch, and then that increases blood pressure. Okay? So this diagram is trying to give you a picture of how plaque develops. So plaque is often caused by chronic low-grade inflammation in the arteries. So if you drink a lot of sodas and you've got a lot of sugar, apparently fructose, but I don't quite understand the mechanism for fructose. And the plaque can just build up and build up, right? And if it ruptures, then it floats off and it becomes a blood clot, right? And then you've got a problem because then it's floating around and it depends where it gets stuck as to how much issue you could have with that, right? So the development of plaques and how they work actually is really fascinating. If you get the chance next summer, if Dr. Barlow runs the advanced cardiovascular exercise physiology class again next summer, it's quite a hard class, but I would highly recommend it. It's really fascinating, absolutely fascinating information. So these plaques, we have risk factors for the development of plaque that are controllable, and we have some that are out of our control. So our age, if we're older than 65, for example, then you're much more likely for a plaque to develop. Being male puts you at more risk than being female. Hereditary, so if you've got a family history of plaque, blood clots, heart attacks, strokes, then you know you need to take extra special care of your arteries, right? Controllable factors, the major one, one of the major ones is smoking, tobacco, your blood lipid profile, which we'll talk about in a little while, hypertension, which we covered a bit in lab and we'll look again at today, being obese or overweight, physical inactivity is a major risk factor for this, right? So you can see over the last few weeks that all the pieces of the pie sort of fit together, right? I need to be regularly physically active at a moderate level. I need to eat a well-balanced diet that is low in fats, high in fibers, has an adequate amount of protein for the amount of exercising I'm doing, right? All these things. It doesn't have to be hugely complicated to be healthy, right? We just have to get people to understand what needs to be done. And that's where the problem falls, right? People either don't understand or they know what's got to be done and they just won't do it. Okay. So stroke is very similar to angina and a heart attack, but in the brain, right? Similar idea. It's the leading cause of disability in the US. Often people will have a stroke and they don't die, but part of their body stops working because part of their brain has been damaged, right? So we've got a similar idea. We've got this blockage in the vessels that are delivering oxygen and glucose to the brain, and therefore the tissue that's the other side of the blockage gets damaged, and depending on how bad the blockage is, can actually die. All right? So we have two types of stroke. The most common is called an ischemic stroke. And if you can see in this diagram, you can see that we've got a blockage of one of the vessels. Okay? So the tissue the other side of that blockage is not receiving enough oxygen and glucose, if any. Okay? Now, where the blockage occurs dictates the kinds of symptoms that we see the stroke incurs for that individual, right? It can be paralysis. It can be connected with loss of memories, like you can't recall memories properly. It could be connected to a particular sensory organ, okay? So about 83% of strokes are ischemic. And here, this blood clot could be a thrombosis, which means it threw in the cerebral vessels. So there was plaque build up or some other reason for a blood clot to develop in one of the vessels around the brain. Or it can be what is called an embolism, and an embolism has traveled from somewhere else in the body. Okay, so that can be quite dangerous. That's one of the reasons, you know, I don't know how many of you have done a really long distance flight, but on international flights, they give you all this information, they make you watch a video, they come around and remind you you've got to be kind of circling your wrists and circling your head, and you've got to stand up and sit down several times and circle your ankles and try to keep the blood flow going. Because a lot of people on long distance flights died of embolisms throwing in their leg and then traveling up, and they had a stroke after they got off the plane, kind of thing. So then the second type, the less common version of a stroke, is a hemorrhagic stroke. And here what happens is that instead of the vessel getting blocked by a blood clot, the vessel actually ruptures for some reason, okay? And there are two types of hemorrhagic stroke. One is a cerebral hemorrhage, so it's kind of inside the tissue of the brain. And the other one is a subarachnoid hemorrhage, so it's on the surface of the brain, but the problem is between the surface of the brain and your skull, there's very little room there. And so if something ruptures inside the brain, it puts pressure on very delicate brain tissue. If it ruptures on the surface, there's nowhere really for this additional fluid that suddenly appears to go. And so then that puts pressure on brain tissue as well. Okay? So these can happen because of hypertension, because hypertension weakens the walls of the arteries, and so then they can rupture. That's called, if it's in the brain like this, that's called an aneurysm. Or it can be due to atherosclerotic damage, where the walls are getting thick and stiff, and that leads to a weak spot that can then rupture. All right? Again, the symptoms and the consequences of these strokes depend on the location and the extent of the stroke. Right? Some people, my mum had several little mini strokes, and she had, and you wouldn't even know it if you didn't know her well. She had ever such a slight paralysis in her lip, and she talked a little bit to the side. But as I said, you wouldn't have, if you didn't know her, you would never even know. It was so minimal. She was very lucky, right? Okay, so another version of cardiovascular disease, so we've had coronary artery disease, we've had stroke, is heart failure. And heart failure is defined by the ventricles not being able to contract sufficiently to get blood out of the heart around the body, and so our cardiac output, our Q number, that should be 5 liters per minute at rest, right, drops down. And then, because it's dropped down, the body isn't getting enough oxygen to work well, and so the person feels very fatigued all the time, right? So acute heart failure can be caused by a heart attack. That heart attack could be a toxic substance, or it could be a coronary artery blockage, right? Chronic heart failure, so long-term heart failure, is often called congestive heart failure, is caused by hypertension. So we've got this blood pressure issue again playing a role. Multiple minor heart attacks, so there's just little spots of myocardium that aren't contracting the way they should. Or there are certain viruses that will attack the myocardium. Okay? So the decrease in Q, oh, that's the next slide. The decrease in Q, right, leads to fluid retention at the kidneys, because what the body tries to do is to make up for the fact that the contraction is not strong enough by providing more blood volume. So the kidneys start retaining water, and that then increases, because we've got an additional blood volume, that then increases blood pressure, and it increases the amount of work. Remember that the left ventricle in particular has to push out against the aorta, and there's all that pressure the other side of the aortic flap, right? So it has to, the ventricles have to work much harder to push the blood out, and that leads to hypertrophy, but not healthy hypertrophy that we get from aerobic work, unhealthy hypertrophy because of the increase in blood pressure. Okay. Then we'll also see fluid accumulation, edema in the ankles and legs, so people who have trouble with their hearts, or maybe don't recognize, again, you know, this could be something that you might be the person that recognizes that they've got a problem and they need to go to the doctor, right? If they've got very swollen ankles and feet and legs, that can be edema due to this fluid retention at the kidneys, all right? They can develop pulmonary edema, so fluid on the lungs, and then they probably won't be in your gym anyway because they won't be able to breathe very well. So it's unlikely that they'd be coming and trying to train at that point. So Q can't be maintained even with this fluid retention enough, and so chronically over time it's just going to get progressively worse and worse and worse if it doesn't get treated, right? And eventually, if this individual doesn't die, they're probably going to need a heart transplant, right? So back to our old friend hypertension. All right, so we looked at this in lab a few weeks ago. And I went to the CDC today and I was looking up because the information in the book was from 2006 or something like that, and I'm like, surely we must have updated information. Oh yes, it's worse. So chronic high blood pressure at rest, so not just a one-off measure, right? An ongoing problem with blood pressure. Anything from 130 or higher systolic to 80 or higher diastolic, okay? Means the heart has to work harder. If the heart has to work harder, then there's increased demand for oxygen and glucose to the myocardium. There's more strain on the artery walls and the arterioles that are even smaller than the arteries. And we've got risk of all kinds of problems coming out of that. All right? It's much more common in people who are overweight and or obese. About 65% of the female population that has hypertension is overweight or obese, and about 75% of the male population with hypertension are overweight or obese. So you can see it's not everybody, right? It is possible. My dad, I've told you a lot about my dad, right? Trains every day. He's been an athlete his whole life. I don't ever remember him not training. When I was little, he played rugby competitively, and then he's always trained in one form or another, right? He has hypertension. He's teeny. He's like this tall. He's lean. He's got good musculature. He's not very flexible. But, you know, he's in really good shape. And he has high blood pressure. It's genetic, right? So he has to take blood pressure meds. So, you know, it doesn't have to be being overweight and obese. So you want to pay attention to the symptoms, because it is always possible that genetically you might be prone to the problem even though you stay in shape and you're not overweight. Okay? I had to update this slide because it used to be 1 in 3 adult Americans, and now it is almost 50% of adult Americans are projected to be hypertensive. So that's gone up quite a lot in the last 10, 15 years, right? And it is indicated in so many diseases that cause death, right? So that's why it's such a big problem and why we want to catch it early. Because if we catch it early, we can prevent it from developing to that level. So I updated this. The numbers on this chart might be a little different to the numbers that I gave you in lab. Because the numbers I gave you in lab came from our textbook, and these numbers are from 2003. And when I was looking at the CDC today, I was like, those numbers don't look right. So that would be because in 2017, the American Cardiology, can't remember what the other C stands for, and the American Heart Association released a new set of guidelines to indicate blood pressure issues. So the numbers have changed quite a bit now. All right, so if you look at your book on page 376, table 13.1 has the classifications as they used to be. So they've changed. So that pre-hypertension is now 120 to only 129, not 139. And you no longer have to be over 80 on diastolic. So that suggests to me that systolic blood pressure seems to be playing a bigger role in leading to full-blown hypertension. Otherwise, I don't know why they would leave the diastolic pressure at the same as normal, right? So systolic blood pressure must be indicated as being a bigger driver of overall hypertension, okay? So if I'm in the normal range, I've got little risk of developing cardiovascular diseases. If I'm in that pre-hypertension range, I'm at some risk. And this is the group we really want to identify and get our hands on, because at this point, we can bring them back to normal without them necessarily having to take medication, right? If they're in that pre-hypertensive state, then if they're willing to change their lifestyle, change their diet a little bit, add some more physical activity, then they could bring their blood pressure down enough to not ever have to take meds, which is always a good thing, right? Then we have serious risk. Stage 1 has changed as well. Stage 1 used to be 140 to 159. So they've cut this stage 1 level dramatically now, right? Only 130 to 139 systolic and 80 to 89 diastolic, which used to be the level for the pre-hypertension diastolic range, right? So that means then that we've got a lot more people who are hitting this stage 2 level of risk, right? Really high chronic blood pressure. And let me just check. I'll show you these quick. How much time have I got? 5 minutes? Okay. Show you this. So this is from the NIH, and it says, note that readings above 120 over above 180 over 120 are dangerously high and require immediate medical attention. Okay? So that's pretty bad. Any questions, Tyler? Okay, so blood lipid profile was one of the risk factors that we mentioned earlier on for coronary artery disease and blood pressure issues. So blood lipid profile, when you go and have your blood work done, they're going to throw some numbers at you, and I think it helps if you understand those numbers. Okay? So, there are proteins in the blood that carry lipids, carry fats, all right? And we have 3 different types of these lipoproteins. So we have LDLs, all right, which are low density lipoproteins, and they're the bad guys, right? And then we have HDLs, high density lipoproteins, and they're considered the good guys, right? And now they might discuss a 3rd group called very low density lipoproteins. I'm assuming those are the really, really bad guys, right? So what we want to look for when we are looking at our blood work are these numbers, right? Are we at little risk, are we at some risk, or are we at serious risk because of our lipid profile, okay? So my total cholesterol needs to be less than 200. My LDLs want to be less than 130. My HDLs, remember that HDLs are the good guys. We want HDLs to be 60 or higher, right? And our triglycerides, we want less than 150. Okay? So this group of numbers would be healthy, right? From there, we see if our LDLs get higher, that puts us at more risk. If our cholesterol gets higher, that puts us at more risk. If our HDLs get lower than 60, that puts us at more risk. And if our triglycerides get higher, then we're at more risk. Okay? Now, another number that they may include for you is the ratio of total cholesterol to HDLs. And it's thought that that might be the most accurate index for risk. All right, so this ratio of total cholesterol to HDLs. So if that is higher than 5, if that ratio is higher than 5, then you're at increased risk. And if it is lower than 3, you're at very low risk for any kind of cardiovascular disease. Okay? So remember that the LDLs are the bad guys. If they're high and your HDLs are low, then you're at extreme risk of a heart attack, even if you're under 60. Right? If we want to be at low risk, we want our LDLs to be low, our HDLs to be high, and that ratio to be less than 3. And then we're like, Superman! Okay? All right, got a couple more slides to do there, and then we'll start talking about our matrix and our exercise prescription. So on Monday, we'll do these last couple of slides, and then we'll start talking about how do we set up an exercise prescription. Okay? Any questions? Okay. Have a great weekend. Stay safe. Use your masks. Wash your hands. Stay the heck away from anybody you don't live with. Okay. Bye.